Welcome, everyone. Just wait a few minutes while we get going. People are logging in. Okay, just take 2 more minutes. Okay, so welcome everyone to our speaker series presented by the Center for Health Informatics. I'm Kathy Eastwood, and I'm an Associate Director of the Center, focusing on strategic partnerships and research within the Center. So at CHI, we are a center that helps to transform data into evidence to be used in the community by collaboratively developing innovative health, informatics, science, and precision health types of projects to improve the health of our population. And in this series, we aim to introduce the extraordinary work of our colleagues in the Center for Health Informatics from near and far. Some are local and some are invited guests. And this platform is designed to enhance our knowledge, form collaborations, potentially co-supervise students as well when we find common ground and topics that interest us and people with the expertise. So today I can see we've got about 17 people logged on. That's awesome. I'm introducing James King. He's an epidemiology PhD candidate in the Department of Community Health Sciences at the University of Calgary, supervised by Tyler Williamson and Gil Kaplan. Alongside his research, James works also as a senior analyst with the Provincial Research Data Services team at Health Shared Services, assisting researchers with access management and analysis of administrative healthcare data. So please welcome James, and we'll leave time at the end for your questions. So make note and raise your hand when you feel able to contribute.
Thank you very much. Yeah, thank you very much, Kathy. So yeah, thank you for the invitation as well to present here today. I'll be talking, I guess, on a specific disease, celiac disease. So a lot of you are not likely working with that condition or researching it, but hopefully it kind of gives an idea of just, how we think about trends in certain chronic conditions and some of the challenges, some of the unique challenges that might come up for certain conditions and how to kind of work through them. And at the end of the day, just, I guess, provide a bit of awareness and education on celiac disease. So before I start, I just do want to acknowledge where I am at the University of Calgary and located in Calgary here for the traditional territories of Treaty 7, including the Blackfoot Confederacy, the Tsuut'ina First Nation, and the Stoney Nakoda, and the city of Calgary as well, being home to the Métis Nation of Alberta Region 3. And kind of in line with some of that Indigenous context, I did want to also just highlight some work that I've been lucky to be a part of in relation to celiac disease and gluten intolerance more generally. With Dr. Rita Henderson has been leading an initiative on trying to understand this type of condition in Indigenous communities. It's, preliminary work, but so far we've really identified that there's a huge gap. There's not much research in this area. I won't go into too much detail in this presentation, but certainly celiac disease is one of those conditions that was for a long time considered to be, primarily affecting people of Northern European descent, which now we know is, again, like some other conditions, it's affecting people throughout the world. It's truly a global disease. So yeah, if you're interested in kind of learning more about this work or wanting to even get involved, then certainly head to that link or reach out to me and I can connect.
James, I just wanted to let you know you're mostly off camera. If you could just center yourself near your
Oh,
camera
sure.
or angle it to where we can see you.
Is that
That's
better?
better.
Okay.
Yeah, thank you.
It moved around a bit today. Um, yeah, so moving on, I'll just kind of show this outline for today, providing a bit of background what celiac disease is, some of the trends in the epidemiology, and this concept of the celiac iceberg, some of the major milestones that has potentially explained some of the trends in that epidemiology. I'll then also talk a bit about some of the work that I've done with others here in Alberta related to celiac disease, and then just touch on some of the implications of what we're seeing within not only Alberta and Canada, but in many parts of the world as celiac disease becomes more diagnosed. So to kind of set the stage a little bit, in the last couple of weeks, I was seeing a lot of reference to this podcast clip in the celiac gluten algorithm that I guess my technology has identified. But basically, without going into too much detail, there was just a conversation about gluten and celiac and kind of this, well, where did this come from? Everyone seems to be getting celiac now, or everyone's allergic to gluten. Didn't used to be an issue. Um, and I think kind of what, again, I'll touch on a little bit in this presentation, where a lot of the, I guess, public discourse around this gluten avoidance or gluten-free diet is kind of, well, is it a true allergy or is it a personal preference? Um, and so that can kind of get things a bit confusing, but when you actually think about celiac disease, it's actually not a true allergy and definitely not a preference. It's actually an autoimmune condition. So, like other autoimmune conditions, the body is mistakenly sort of attacking itself in response to some kind of perceived danger. And this really happens in the small intestine. So, what you see here are these finger-like projections called villi, which this is what they would look like in a healthy individual without celiac disease. And these villi are really useful for absorbing nutrients and vitamins. And then for someone with celiac disease, or specifically untreated celiac disease, what will happen is when they consume gluten, which is a protein found in wheat, barley, and rye, is that these villi actually get blunted and there's considerable villus atrophy. So it becomes really difficult to properly absorb nutrients and vitamins. And so you can imagine lots of potential complications and symptoms can arise from that, not just gastrointestinal, but also some others that we'll discuss. And so then there's some other immune dysfunction that's happening. As I said, there's this specialized T cells that, again, there's kind of this thought, oh, gluten is something bad, and in turn, kind of the body, yeah, has that autoimmune reaction. In terms of the celiac iceberg, it's a pretty classic analogy that's also present in other conditions that are often unrecognized or undiagnosed. But for a long time, we've identified that people with diagnosed celiac disease are really only kept this tip of the iceberg, and there's a lot of people that remain undiagnosed. And um, even some recent work. This is a study from Norway from a little over a decade ago, and they basically found that among a cohort of the general population, of the people that had celiac disease, only 25% or one in four had been diagnosed prior to the study. So again, a lot of people being missed in that sense. In terms of a pediatric cohort, this is another recent study from Italy. And yeah, still, more than half of children that were screened in this study did not know they had celiac disease when the study took place. And this is quite, I think, actually worth noting too, because Italy is a place that generally has quite high awareness and screening practices for celiac disease. They've actually started to introduce and pilot mass screening. So it's quite important to note that even there's quite a discrepancy in that diagnosed to undiagnosed ratio. And a lot of this has to do with, again, there's some genetic components to celiac disease, and so there's some variation in the actual prevalence of celiac disease throughout the world. Um, and what you'll see in the orange here are the prevalence estimates based on kind of the gold standard for diagnosing celiac disease, which is actually based on a biopsy of the small intestine. Um, but as I'll talk about a little later, you also have this seroprevalence, which is based on the actual blood screening test that's used to first identify potential people with celiac disease. So there will be some false positives in there, but you can see that there's quite a big difference between the estimated seroprevalence based on the blood test compared to actual diagnosed celiac. Um, and so certainly that's another key indication that a lot of people are being missed throughout the world. Now, when you look specifically at the incidence of new diagnoses, um, and this is primarily coming from industrialized countries throughout the world, so it is a bit of a gap in the literature, but um, when you look in the last 20 to 75 years, um, we certainly knew celiac disease existed in the 50s and 60s, but it was really around the 1990s and the 2000s that the incidence really ramped up and more people were getting diagnosed, which includes here in Canada. And so that does kind of, again, touch back upon that initial podcast discussion. Why are so many people getting celiac, or why is gluten being so become such a pressing, I guess, issue or discussion point in the last 10 to 15 years. And so this is kind of one, again, piece around that public discourse, perhaps. There were some pretty um, high-selling books that came out about 15 years ago on not just gluten and wheat being harmful to some people, but just kind of being generally something that might be bad for our health. A gluten-free diet was quite popularized by some celebrities and athletes, and then there's been all kinds of speculation around what is it? Is it something now that's in our wheat or gluten that's changed and that's causing all these potential health problems? Um, this is again kind of highlighting that huge shift where a lot of the time in sort of the mid 2000s there was a lot of variety in what kind of diets people were potentially curious about or trying to adhere to, and then in 2015, yeah, there was just this huge shift and a lot of people looking up the gluten-free diet, and the industry really kind of took a boom. So when you start to further actually try and break down a little bit of some of the key milestones to try and actually see, okay, well, what else could be explaining this? I mean, a lot of the times in epidemiology and just any kind of data science. We really want to be careful around mistaking causation when it could be some type of correlation. So, as I mentioned, the 1950s and celiac disease predates this, but this is really when we understood more about it and could actually identify that this gluten, this protein was the key factor in causing this autoimmune response. And we were able to identify that the disease activity was happening in the small intestine through the biopsy. Again, at that time, it was initially thought maybe more so a pediatric condition, and primarily would present with your typical gastrointestinal symptoms like diarrhea and sort of failure to thrive, as it were. Then, as time went on, we could identify some blood tests to actually identify these antibodies as a screening mechanism to first see, okay, who maybe is at risk for celiac disease before we go straight to taking the biopsy. And there was also the identification of some of those genetic markers that were required and necessary for someone to actually develop celiac disease. And then really these last three are where again you start to see that huge rise in incidence, and I'll go through some of these in a bit more detail, but really there were some major changes where the tissue transglutaminase, or TTG, was another new screening test that was more accurate and more cost effective for screening celiac disease than the prior ones. Um, so there was this major adoption of that screening tool. There was improved knowledge around celiac disease. There's other symptoms that people will have, like iron deficiency or chronic fatigue, even dental enamel defects. Um, Further recognition that adults will be diagnosed, and so you see this average age at diagnosis rising. And then more recently, in the 2010s, and even in the last few years for adults, there's been some changes in guidelines where some people can be diagnosed with celiac disease without that gold standard biopsy. So again, it's just making it easier to identify patients um, without the invasive procedure. So to provide some examples of some of these key milestones, if we look at actually a Calgary-based study, they actually found that the incidence of pediatric celiac disease more than tripled after this antibody screening was introduced. So again, kind of a better way to detect potential cases, improved awareness around celiac disease happening in this time. So certainly helping to unmask more people that would have maybe in the past been undiagnosed or remained undiagnosed for a long time. Um, Initially, those what are called classical symptoms of gastroenterology, maybe 75% or a majority of patients that were diagnosed would, report having these symptoms or or several of these symptoms, whereas now we see those things like iron deficiency, even migraine or headache, and it's actually the majority of diagnosed patients reporting those. So um, again, it's likely that a lot were being missed in prior work because those symptoms and disease presentations weren't as well recognized. As I said, some of the guidelines, particularly in Europe, have changed. So this was an update in 2012 to the European guidelines, where if you had certain measures on that TTG test, your antibodies were, really high, and you also had some other characteristics like symptoms, also positive for the genetic marker, then you could officially make the diagnosis of celiac disease without going through and actually taking a biopsy of the small intestine. Um, so if you look at this study that was done in Scotland that overlapped with the new guidelines, you can see overall that incidence of celiac disease was increasing throughout that time. And since the implementation of the new guidelines, 1 in 4 children were diagnosed without a biopsy, and over half were diagnosed without a biopsy in the last year of this study. So certainly, again, it's making it easier to identify more people without the need to have maybe a referral to a gastroenterologist or internal medicine physician to go through that procedure. And even more recently, so this is just from last year actually, the European group has now basically said something similar in regards to adults. So um, kind of a similar type of approach where you're seeing the adults that have really high antibody levels. Um, there's confirmation of these antibodies in a second sample, and basically you can proceed with a similar approach and say, this person is so likely to have celiac disease that we can forego having the upper endoscopy procedure for the biopsy. And again, although that's European guidelines, this is a recent survey of Canadians with celiac disease, reporting, their diagnosis and symptoms, all those kinds of things. And this was done in 2022. And so when you actually look at the participants who were diagnosed, more than 25 years ago, only maybe 5 or even less than 5% reported being diagnosed by the biopsy, or sorry, by serology only. Um, and then there's kind of that trend as we get closer and closer to more recent time period that maybe almost 30% are reporting their diagnosis based on serology. So again, it's probably something that's happening here, whether or not it's officially being diagnosed, or maybe again, individuals are taking into consideration family history of celiac disease and symptoms, that kind of thing. You're seeing more and more people that likely have celiac disease without a biopsy confirmed diagnosis. One other consideration that's important, I think, for some of the studies that have been done on the incidence of celiac disease is that maybe there's also been a mechanism of improved coding in health services data, which is something we've seen with other conditions. Um, and so this is a study that was done in Denmark and was able to actually go all the way back to the 1980s up to 2016. And so they did see a pretty clear increase in the incidence of diagnosed celiac disease throughout that period. Um, but what's important to note is that they also had a shift from the 8th version of the ICD coding system to the 10th version, to the ICD International Classification of Coding of Diseases. And so with that 10th version, there's some more specificity. So perhaps part of the actual increase that we're seeing is just, again, better coding or better quality of data, as opposed to just an increase in diagnoses. Similarly, this was a study that was from the United Kingdom, and they looked at actually 19 different autoimmune conditions based on ICD codes. And among these 19, celiac disease actually saw the highest increase between 2000 and 2019. So certainly something, again, to consider in some of these studies, how much of that increase is from more diagnoses or perhaps, yeah, changes or improvements in coding of the condition. So those are some key, um, I guess, yeah, considerations, milestones in studying celiac disease and understanding the condition better. But is that really the only reason we're seeing an increased incidence, or more and more people are getting diagnosed. Um, well, if we look to another study from Finland, which is one where they were able to essentially compare stored blood samples of a similar cohort in the same region. One that was from the late 1970s, and then one that was from the early 2000s. So in that first sample, again, you can see the vast majority of individuals at that time were undiagnosed. Only 3% had been diagnosed with celiac disease. Um, and then by 2000, certainly a lot remain undiagnosed, but a noticeable improvement where now 26% had been diagnosed from that blood sample. But what's also important to note from this work is that in terms of the overall prevalence in those samples, the first one estimated about 1%. So about 1% of the sample had these antibodies for celiac disease, whereas the follow-up study about 20 years later went up to about 2%. So there were actually not only more people diagnosed in that period, but there was a higher true prevalence of celiac disease beyond just better recognition. And this is a pattern that's not just been observed in Finland, but it's been observed in a few other places with some similar study designs where you've been able to compare some historical cohorts that were screened for celiac disease or celiac disease antibodies, and then compare it to a more recent cohort, and you do actually see that the prevalence, the absolute prevalence of celiac disease has gone up in um, those research studies. So there's been a lot of work to try and understand, okay, there seems to be evidence for a genuine increase in celiac disease beyond the better detection and better recognition. One of the most notable data points is this so-called Swedish epidemic of celiac disease, where in the mid 1980s to 1990s, basically 3% of children born in that time period went on to develop celiac disease, which again is a much higher number than what we've seen in most other studies and other contexts. Um, and then you did see kind of a noticeable drop off after that, followed by a subsequent increase. And so one of the, or I guess a couple of the key questions that kind of came out around that time was, well, there were some changes to the guidelines for breastfeeding, as well as the introduction and timing of gluten or wheat into the diet. So, you know, is there something there where that really early life exposure to certain things or the combination, is that what's potentially going to drive up the occurrence of celiac disease? Um, you've seen, again, this is a bit more of an ecological look at the relationship between wheat and celiac disease prevalence. Not necessarily a clear, definitive correlation, um, but maybe some suggestion that countries that have higher wheat consumption maybe have a little bit more are a little bit more likely to have a higher prevalence of celiac disease. But again, not entirely clear. And so these are uh, some of the some of the speculated or risk factors that seem to have a bit more stronger evidence to actually be increasing the risk of celiac disease. Um, so actual prospective birth cohort study that has looked at children who are genetically predisposed and at high risk for developing celiac disease, they did actually find that increased gluten intake in early life was associated with an increased risk of celiac disease. There's been some other findings where vitamin D exposure is related to increased celiac disease risk, and it's not a linear trend. It's actually seeing that if you have comparatively lower and comparatively high or comparatively higher vitamin D concentrations, that you might have an increased risk for celiac. Um, in terms of things like early exposure to infection and antibiotic use, there seems to be some evidence there as well that these might increase the risk of celiac disease. And Quinn Goddard, who is working actually on some of this type of work with Alberta data right now, we're also seeing some similar results there. And then similar to some other chronic conditions, outside of gluten specifically, you do maybe see that there's a decreased odds or risk of celiac disease, with a more conventionally healthy diet, with, less processed foods, refined sugar. So these are, again, not exhaustive of the potential causes or risk factors for why we're seeing such an increase in celiac disease, but some of the ones that have shown sort of the most consistent or the most evidence in the last little while. So ultimately, with this iceberg, yes, we are diving deeper. We've had some major strides in being able to, screen a lot of people with the TTG, greater awareness and um, understanding of non-gastrointestinal symptoms, and just sort of an overall improved knowledge and awareness, again, within not just the sort of the medical community, but also the general public. Again, perhaps from some of that gluten-free diet industry boom. More people might be curious about if they have celiac disease and asking their doctor to get screened, whereas maybe in the past they wouldn't have. But as we see, there's also some evidence that the iceberg itself is actually getting bigger, and there's more people that are developing celiac disease than there were in prior decades. So yeah, I'll move a little bit into the Alberta context and describe some trends in the epidemiology that we've seen here in the last decade or so. But before going into that, I do just want to highlight some of the challenges with trying to study celiac disease here, using sort of secondary health services data. There's not been a ton of work done in this area, in the Center for Health Informatics, and a lot of the work that's done here, we're using some pretty well established algorithms to accurately identify people with a particular condition. But with celiac disease, there's really not a strong reference point. So there was some work done in a pediatric population in Ontario about 10 years ago, and they relied on the ninth version of ICD codes and some billing codes for endoscopy, but ultimately found that this was not a very useful or accurate way to identify children with celiac disease. Positive predictive value only 53%. And really, this is because celiac disease is a bit tricky. It's mostly managed in outpatient settings, or you're seeing maybe your family physician um, a lot of the time, and if you do get the biopsy confirmed diagnosis, you've done that procedure in an outpatient setting. So a lot of these records are maybe not available, or they're just not coding celiac disease per se. Another challenge is that the treatment of adhering to a strict gluten-free diet this is not something that's going to show up in some type of drug database or even, there's no procedure to treat it. Again, it's a diagnostic procedure. And a lot of the times that procedure is done investigating for celiac disease without actually knowing what the results will be. So you typically won't get that actual ICD code um, in the actual endoscopy record. But one of the big advantages that we have in Alberta and has been taken of advantage in other countries is the laboratory data, because there's now that um, large scale use and implementation of the TTG antibody test. We can at least look at this measure of potential celiac disease or probable celiac disease based on that test and look at some trends that way. So yeah, essentially similar to many other projects done in Alberta and elsewhere in Canada, basically linking and identifying patients that have this index TTG positivity, so they're newly positive for this celiac disease antibody, what is often called celiac or celiac disease autoimmunity. And then, yeah, we have opportunity to link to several other healthcare encounters to try and maybe validate a diagnosis, look at healthcare utilization, and look at other maybe risk factors of disease, like I mentioned, or adverse outcomes compared to individuals without celiac disease. Um, and so some of the initial findings from Alberta, basically this study went kind of right up to the pandemic, right before the pandemic so this went up to March 2020. If we just look at the overall screening for celiac based on that TTG, basically per region, we can see that those city centers of Edmonton, Calgary, the more metropolitan regions, there seems to be more testing and screening for celiac disease in those areas compared to more rural or remote parts of Alberta, which is not unsurprising. We've seen something similar in other countries and with other health conditions. Maybe there's just more concentration of screening in these areas. A higher number of gastroenterologists or internal medicine physicians or specialists that might have been referred individuals at risk or suspected of celiac disease. And unsurprisingly, you kind of see a similar breakdown of the map when you look at that actual incidence of celiac autoimmunity or being newly positive for the TTG antibodies, where again it's a higher incidence in Edmonton and Calgary areas, although some high areas as well, maybe in southern Alberta. In terms of breaking this down across age and sex, not so surprising again, based on what we've seen in other studies and the epidemiology of celiac disease. In early childhood, you see a pretty similar level of screening in females compared to males. But as you maybe reach adolescence or teenage years and onward into adulthood, females are being screened more frequently than males. And that kind of, again, persists for most of adulthood, which, again, there's some evidence that maybe the actual risk of celiac disease is slightly higher in females compared to males. But we also know that perhaps there may be health differing healthcare behavior, certain events like maybe pregnancy, which could maybe trigger or there could be an onset of celiac disease symptoms that maybe make females more likely to be screened. But certainly it's an area that could could suggest there might be an underscreening or still um, more males or more men being missed um, under that iceberg. So this is now looking at the actual incidence of the celiac autoimmunity. So again, even though those screening rates were similar in early ages, you do sort of see a slightly higher, potentially slightly higher incidence in females. So providing some potential speculation that there is that genuine difference, um, and then a clear difference in adulthood, and maybe starts to be similar um, into later life. And just updating some of these trends since the pandemic to see kind of what's happened, or maybe what some of the changes that might have happened during and after the pandemic. Um, so this sort of teal blue is showing again that screening rate. So there was a dip in actual testing for pediatric celiac disease, and so a similar kind of dip in the actual incidence of the celiac autoimmunity, and then seems to kind of rise after 2021 and onward, and then maybe almost plateau or be sort of stable since 2023 in the last couple of years. Um, and so we did some analyses to actually compare the trends before and after the pandemic, and for the pediatric population, kind of saw that there was no detected no meaningful difference, but visually you can kind of see maybe a little bit of some things happening. And so it'll be interesting to see in the coming years what happens. There's some certainly case that a lot of non-urgent or chronic health condition screening went down in the pandemic, and so maybe this increase is sort of a catching up and identifying potential cases of celiac disease that would have been identified earlier, but just that general reduction in healthcare utilization further delayed that. Um, Sort of a similar pattern with adults, maybe not as clear of a increase right after 2021, but it did seem to suggest from the analysis that things were a bit stable for adults prior to the pandemic, and maybe is starting to increase post-pandemic. So again, it's going to be important to see among those that were identified maybe in the years following the pandemic, is there um, further risk or adverse outcomes from a delayed diagnosis? Hard to tease that out fully with this type of data, but something that we'll be considering um, in future years. And then to again bring back some of the challenges with studying celiac disease, we do have some potential ways to at least link this cohort to see whether or not they had the procedure done to actually investigate for celiac disease. So again, this record or this procedure is not necessarily going to be diagnostic and have an actual code for celiac disease, but it could maybe give us a clue that this procedure was actually done soon after the TTG result. So we linked to a few different data sources. So a billing claim from the practitioner claims database. Again, it's not super specific, more of a general, non-operative gastroscopy procedure. And then a couple of other codes from the Canadian Classification of Health Intervention, which are going to come up in the NACRS or DAD database, so the National Ambulatory Care Reporting System, and the Discharge Abstract Database. So those are, more specific and detailed definitions of what that code represents. But some of the challenges here is that these, again, are encounters that are non-urgent. It's not considered something like a day surgery. And so in the context of the knackers data, that's not something that is mandatory to be reported. So it is one of those things where they might come up for some patients that had it, but other patients that actually had the procedure, there just might not be a record for it. And this is just looking at that actual linkage to kind of see what comes up. So if you just look at um, the blue bars and the proportion of patients from the cohort is on the y-axis across age, you can see some variation, but about 50 to 60% of the cohort had some kind of record for the procedure. When you also include whether or not they had an actual ICD code for celiac disease, then that number goes down even further. And so initially there was a thought, well, maybe this is, yeah, maybe we're undercounting the actual amount of people that had the procedure done. It's possible that this is capturing sort of the actual truth of how many are getting the procedure, but without proper validation, it's sort of difficult to say concretely. So yeah, really just a cautionary interpretation with that initial linkage. We don't really know if that's capturing it well, especially with the more specific codes. We might be missing a lot of records or a meaningful amount of records. Um, and so what's actually quite exciting now is that we can now link using the Connect Care data, so the electronic medical record system launched throughout Alberta gives us the ability to actually link these patients to pathology results. Um, and so not only will this be able to show us, who had the procedure done, but the actual interpretation and the pathology report to confirm whether or not the biopsy showed evidence for celiac disease or didn't show evidence for celiac disease. And so, yeah, this opens up a lot of nice opportunities. We can understand how many people are actually getting the procedure done. How does that differ across, demographic or other patient level characteristics? What are the different potential clinical outcomes for people that have a confirmed diagnosis by biopsy versus those that are just TTG positive? And then potentially, um, after getting sort of this gold standard through manual review, potentially automating that process to classify people into whether or not they had the confirmed diagnosis. Some of the challenges, though, at least initially with this data, is that they can be variable in how much detail is provided. So oftentimes with celiac disease diagnoses on biopsy, you'd have something like a Marsh score, which would indicate how severe the intestinal damage and inflammation is. That's not always there. We haven't yet brought in information from an endoscopy report, which looks like we should be able to do still in the future. And that's going to contain some information on things like hopefully symptoms, some of the initial findings from the endoscopy procedure, if they found maybe evidence for celiac disease before the biopsy was analyzed, and things like that. And then ultimately, with a lot of this type of data, there's just going to be some variation in that reporting across pathologists and clinicians. Okay, so yeah, I think we're okay for time. Just to wrap up with a few considerations and implications of the overall trends that we've seen throughout the world. And again, we saw some increases in incidence in Alberta. So what are the future directions to think about this? So yeah, this is a condition that I don't actually think I mentioned at the beginning, but it is chronic. So the treatment of gluten-free diet is the only treatment. There is no cure. for the condition. There are some clinical trials ongoing to develop potential adjunct therapies with the diet to help sort of reduce the autoimmune response. But still, currently, that diet-based treatment is all that there is, and some research has shown that that treatment can carry high burden, not just for individuals with celiac disease, but also for caregivers. So especially in the pediatric context, because parents and guardians are, primarily responsible for feeding their children. They take on a lot of that burden, um, and of course, with untreated celiac disease or poorly treated celiac disease, there's increased risk for developing other autoimmune conditions, other comorbidities, osteoporosis, certain malignancies, and psychiatric conditions. And while not a universal pattern, um, we do see a lot of places, and that includes Alberta, where the highest incidence is still in children. And so again, that's going to be something that the population is living with for a long time, and so will potentially need considerable follow-up and management um, in that condition. And yeah, just to kind of highlight one example of this with Alberta data again, using that cohort, this is some work also led by Quinn Goddard. So we basically were looking at the the usage of psychiatric medication before and after this index TTG. So sort of after this celiac autoimmunity identification or potential diagnosis, was there a change in the usage of psychiatric medication because there's been a well-established link between celiac disease and certain conditions like depression, anxiety disorders. Um, and so we wanted to actually see, okay, well, does that actually manifest in terms of a potential treatment for those conditions? And we did see um, that there was that clear difference. There was some variation by demographics, so there was an increase overall, but not specifically males when you broke down into females and males. Um, the the change was the most pronounced, concerningly, in younger age groups, and older adults or adults 25 and older actually saw a decrease in usage. So um, yeah, something important to consider in post-diagnosis or post-identification of celiac disease in terms of these commonly prescribed medications for those conditions. Um, and yeah, finally, there's another really recent systematic review and meta-analysis that came out, and they looked globally at the adherence to a gluten-free diet among those with celiac disease. And ultimately, while there was variation across different countries, a pretty clear take-home message that there's a lot of, a meaningful amount of individuals who are not able to fully adhere to a gluten-free diet, whether that's intentional or accidental consumption of gluten. It does still really indicate the limitations of this treatment for celiac disease, and how it doesn't necessarily um, meet the needs, or is not as feasible for many individuals. Um, so yeah, I think this is the last slide. This is a potential application of these epidemiologic stages, which have been previously described in the context of inflammatory bowel disease. And potentially we're seeing similar trends with celiac disease, where certain countries start to see a really clear rise in the incidence of the condition. Perhaps certain countries are getting to a stage of maybe that incidence is stabilizing or decreasing even. Um, places like Sweden and Finland, but you still have a high prevalence of the condition because it is, again, chronic. It's not necessarily, it's still quite a low mortality condition, so people are going to still live a long time with the condition. So it's something that needs to be considered in terms of, who will be responsible for caring for people with celiac disease, how much of that is in the formal health system and self-managed with a diet and other alternative approaches. Um, but yeah, I think I will leave it there. Thank you all for listening and joining, and to all my collaborators and funding for supporting this work. So hopefully we have a couple minutes for questions at least.
Yep, a few minutes for questions. I'm taking over for Kathy.
Okay.
Feel free to write your question in the Q&A, or you can unmute yourself or raise your hand. Do you have a question, Larka? It looks like you might. Maybe not. Well, maybe I'll ask a question then.
Sure.
I'm sort of curious how much like other similar conditions muddy these waters, like wheat sensitivities you hear, and a lot of like the small like compounds on wheat would also have like similar effects, but not quite.
Yeah, it's a tricky one. And again, I don't know as much about the other conditions, um, other than there is a condition recognized as non-celiac gluten sensitivity. So it is a type of condition where, again, there's not that autoimmune response, but there's seemingly some kind of symptoms that come up from consuming gluten. It's hard to really say what the prevalence of that is, just because it is more of a, from my understanding, more of a subjective, or again, it's not as easy to diagnose because you're maybe just ruling out celiac disease, but you're still seeing similar symptoms. Um, I mean, from a secondary health services data standpoint, I don't think there's been much to look into that condition specifically, to see how prevalent it is. Wheat allergy. So there is kind of a true wheat allergy as well, I believe, but that is quite rare. Um, but yeah, I think it does just bring up that point, like you said, studying this can be really muddy because um, there is some other conditions or related conditions, and even I didn't mention, but in order to have sort of a sensitive or accurate result from both the screening TTG test and the biopsy, an individual needs to be consuming gluten. So, because there can be potentially a few months between that initial screening and the procedure, um, you know, we we can probably assume that there's people that will kind of say, well, I have a really high TTG result. My brother, my sister, my dad has celiac disease, so I have potential genetic risk. I have really bad symptoms, so I'm just going to try going gluten free and see how I feel. Um, and so those people, again, we can maybe see them through the lab data, but we're not going to have a confirmed diagnosis, even though they probably have celiac disease or they have a high probability. Um, and again, because we don't necessarily know their diet regimen with administrative data, it becomes even harder to know, what happened after that TTG result because they don't come back with anything in the system.
Very interesting. Well, I see there wasn't a question, but Celiac, thanking you for the talk. And it's clear that you've done a ton of research on this, so it's nice to have it all collected in one space too. I really enjoyed that.
Yeah. Well, thank you. And yeah, happy to answer any questions on email too if you want to reach out.
And the talk is going to be posted online on the CHI website if anyone wants to go back and visit highlights. But other than that, thank you so much for giving this, James. This is great.
Thank you.
That, I guess we can say goodbye.